From the American Association of Nurse Practitioners, I'm your host, Dr. Sophia Thomas, and this is NP Pulse, the voice of the nurse practitioner. Welcome to NP Pulse, AANP's official podcast, bringing you unique nurse practitioner voices and issues that matter to NPs and our patients. Ticks can transmit viruses, protozoans, and bacteria, causing more than just Lyme disease. Join us on NP Pulse as we speak to returning guest and my friend, Dr. Vanessa Pomarico-Denino, on what NPs need to know to recognize and to treat these infections appropriately. Welcome to NP Pulse, Vanessa.
Thank you so much for having me back again.
It's been great to have you back. Now, the last time you were here on NP Pulse, we talked about LGBTQIA issues, a lot different than what we're going to talk about today, which is tick-borne illnesses. Before we get into that, though, I want you to just remind our listeners and viewers of who you are and what you do.
So I am a family nurse practitioner at Connecticut Medical Group, which is part of Northeast Medical Group in Connecticut. We have 140 offices between New York, Connecticut, and Rhode Island.
Wow.
I'm the lead clinician for diversity, equity, inclusion for all of those offices. And I am also on faculty for Fitzgerald Health Education Associates, where I teach review courses. And I am the co-chair for AANP's Special Interest Group on Diversity, Equity, and Inclusion.
Wow, that's a lot. And I know you started out as a medical assistant, right? And
sure did.
I started out as a ward clerk and then a nurse's aide. And so we both moved our way up into healthcare.
My mother always said if you were going to learn the profession, you needed to learn it from the bottom up.
And that's what we did.
We sure did.
So how do you go from then being an expert in diversity, LGBTQIA, family nurse practitioner, to be a nationally known expert in tick-borne diseases?
When you become a consumer of an infection, you then become an expert. So many years ago, it's actually 8 years ago, I was in my doctoral program. And my mother had gotten very, very ill and was hospitalized for 28 days with a tick infection. And while she was in the hospital, I developed a rash on my neck, and I didn't think anything of it, put cream on it, nothing was working. Went into my dermatology office and said, "Could you tell me what this is?" And she said, "You have Lyme disease." And I'm like, "No, I don't." And sure enough, she did the blood work on it, and it came back as babesia, which was the same infection that my mother had. My mother was critically ill because the elderly tend to not do as well. And after I recovered from it, I thought more people need to know about this kind of emerging strain of tick infections. And I learned everything. I learned a lot while she was in the hospital, but because I practice in Connecticut, Connecticut is where Lyme disease originated from, Lyme, Connecticut. So we see a tremendous amount of patients who have tick-borne infections.
Wow. And then do you know where you got it?
I literally was we narrowed it down to 30 minutes in my mother's backyard. I had come back from a conference. I was taking up my last class of my doctoral program. So every night I was in school, and it literally narrowed it down to 30 minutes in her backyard. That was the only time I had been outside in the 2 weeks preceding. And that was the only place that I could have gotten the same infection that my mother did. So I often say that there was a tick family that was looking for the Pomarico family to get us both sick.
Wow. So there are a lot of different tick-borne illnesses. People think of ticks as just the creepy crawlies that, latch onto your skin. I remember when I was a child, I had ticks. I grew up in Rhode Island, and this was back in the 70s. But nowadays, tick-borne illnesses are severe and they're widespread, right?
They're everywhere now. So it's not just in Connecticut. It's everywhere. It's all throughout the United States. Every state has some form of tick disease, not just Lyme. But we also see it in Asia, Australia, and other parts of Europe. It's everywhere.
And what kind of diseases are they? I mean, it's not just Lyme, you said. What are the other kind of tick-borne illnesses, and how do they present?
So Lyme is the most common tick-borne disease in the country right now, but there's also babesia, Ehrlichia, and anaplasmosis. Those are the most popular ones. There's a few other ones that tend to affect more farm animals that are not necessarily human transmitted, but those are the big four that we see in humans.
And so what is the clinical presentation of these illnesses?
Usually flu-like symptoms. So the peak season for ticks is usually in the summer, right around now, June, July, and then we see another spike in the fall, October, November, right when people are doing leaf peeping or it's a little nicer out. But we see this is the time of year that we see the peak of them. And so more people are outdoors and they come in complaining of summer flu. Well, we know that generally the flu isn't around in the summer. So when they come in, they have a fever, they have body aches, they might have a little bit of nausea or malaise. They just don't feel well. And after a few days when they're not getting better, that's usually when they come in. Some people, only about 50%, will get the bullseye, the classic bullseye, which is an erythema migrans. But sometimes it's in an area where people won't ever see it. It could be in their head. It could be anywhere that there's hair. It could be, in the folds of their skin or on their back, and they don't necessarily notice it.
And so I just had an NP colleague move from the upper United States into Maine, and she said she has started seeing a lot of tick-borne illnesses. And everybody learns about Lyme disease and Rocky Mountain spotted fever when you're in your program, but unless you see it often, you forget about it. So she's having to really educate herself and re-educate herself as she's seen so many different presentations of these tick-borne illnesses.
So they all pretty much mirror the same onset of symptoms. But Lyme, as I said, will have the telltale erythema migrans, if you will. The other ones won't necessarily have that. The hallmark of like Rocky Mountain spotted fever is conjunctival irritation without the actual conjunctivitis that we typically see. They would just have the conjunctival irritation. That's a hallmark for Rocky Mountain spotted fever. But unless you run the full tick panel, clinicians tend to just run a Lyme test and they don't run the rest of them. And they say, well, your Lyme is negative. And we know that the Lyme tests are not 100%, which is another area of research that we need. But if they don't run the rest of the panel, then patients typically will walk away not knowing that they're infected with a different type of tick-borne illness. So it's really important that clinicians do a tick panel, not just a Lyme titer.
Okay. And in the reference labs, it's called a tick panel.
You have to actually order them separately, but if you tell your reference lab, could you just do a tick panel for me, they will develop it so it's on your order sheet.
Okay. And do you know the names of the lab tests that are in the tick panel?
So you would order it as Lyme, Babesia, Ehrlichia, and anaplasmosis.
Okay.
And then they just put that together. So when you're ordering it, let's say on your electronic health records, or if you still have the triplicate forms, you would just check off tick panel, but just have your local labs develop that. So it's just one stop instead of 4 things you have to look up.
Okay. How long does it usually take these labs to get run?
Well, that's an issue. So it can take anywhere from 4 days to a week.
Wow.
And if there's a high index of suspicion that the patient has it, I always say go ahead and treat, because you'll be a little bit ahead of the game. What's the worst thing that can happen? If it comes back as negative, you stop it. But generally, the more you see it, the more skilled you get at saying, yeah, this patient definitely has this, and they start to feel better on the antibiotics. So that's one of the issues with the labs, is that they're not infallible. And so many times if you test too early, it could be a false negative. And that's one of the issues that we're looking at, some of the other newer technologies coming down the pike that are not quite developed yet. But if you test too early, it could be a false negative. And so I generally recommend that if you have a high index of suspicion, if the patient has a known tick bite or they have other symptoms, if they're negative to begin with, then retest them again in 3 weeks, because it takes about 3 weeks for them to seroconvert.
Wow. And during that time, they're sick, not feeling well the whole time, too.
Some of them are pretty sick, and doxycycline is the treatment of choice, which is wonderful because we can treat Lyme, ehrlichiosis, and anaplasma. If you have babesiosis, that's a different treatment. But if you're lucky enough to have Lyme, Ehrlichia, or anaplasmosis, it's all treated by doxycycline. So even if you're co-infected, which many ticks carry more than one infection, then you're going to get treated for both of them based on one antibiotic.
And what is the length of the course of treatment?
So it can be anywhere. It used to be a full 21 days all the time. And now the newest data is showing us that for anaplasma or Ehrlichia, you can get away with 10 to 14 days. If it's true Lyme, and if the patient has really severe symptoms, we tend to do the 21 days, but you can get away with 14 days. The CDC does recommend that if they have a mild case, you can do it in as little as 14 days.
And what do you do in the cases? I mean, pediatrics, again, I was bitten by many ticks as a child. Pediatrics, and we worry about the teeth development. Do you go ahead and treat with the doxycycline in pediatric patients as well?
So we do, and that's a really interesting concept. So we know that tetracycline has the molecule for pregnant women or for young kids who have not gotten their adult teeth yet, that it can cause a permanent tooth staining. So even in utero, if the mom was given tetracycline, which is why we don't give it during pregnancy. doxycycline is made of a different molecule. So even though it's in the same cycline family, it's not molecularly as correct as tetracycline is. So it doesn't affect the teeth. And they actually they did a study in 2013 where they had young children under the age of 8 who were given a blinded study, and they were given doxycycline or a placebo, and they found that there was no tooth staining with those who received it. Now, you know that whoever was running that study probably had to give lifelong dental care if it ever happened, but it doesn't bind as readily onto the calcium as tetracycline does, and that's why you don't get the tooth staining with doxycycline. But there's alternatives. You can give them ampicillin, amoxicillin will work just as well, although you do have to make sure that they are, especially in the highly endemic areas, that they're not treating for something other than just Lyme disease with amoxicillin.
Okay. And what about long-term sequelae of Lyme disease and these other diseases? Are there, after treatment, some people stay sick for a long time, right?
They do. So those are usually the patients. People sometimes say that they have chronic Lyme, and we have moved away from that term because it implies that they've had doxycycline or they've had an antibiotic and that the parasite is still in them. Where in fact they've been treated, so the infection is gone. But what it does is that they found, the research now shows that it may have triggered an underlying undiagnosed rheumatological disorder or an inflammatory disorder that people feel that they have these chronic symptoms like joint pain, myalgias, brain fog, fatigue, that it can go on for months and months and months.
Mm-hmm. So is this something that they would eventually have developed anyway?
If they probably would have developed it. We see it a lot in people who were undertreated, or people who waited too long to get treated, or people who might have had a negative first test and the clinician didn't run the second test to see if the patient's seroconverted.
Okay.
So it's actually called post-Lyme treatment syndrome.
Okay. Interesting. And so I think what's important to note here is you said that tick-borne diseases are not just now limited to the Northeast, they're not just limited to Connecticut, and anybody across the United States could theoretically have a tick-borne disease. I guess including in my own state of Louisiana, which I never thought of. So all clinicians should really be educated and aware of this, not those that just live in the Northeast or I guess out in Colorado.
And that's so true, because we have to think about where our patients are going on vacation or where they might have traveled. So if we have a patient that you're seeing a patient in Louisiana, and sometimes they can have symptoms anywhere from 3 to 30 days, it can incubate. So you might say, any new soaps or detergents because they have a rash, or, have you been doing any heavy lifting? Whatever it is that they're coming in for, that, you don't want to just say, well, this is just a viral syndrome. Where have you been recently? Have you traveled anywhere? Maybe they traveled to Connecticut. Maybe they went up to Maine and they were hiking. Mm-hmm. They might have been in the White Mountains. And I always say, no matter where you go, you have to think about using some type of tick repellent. And a lot of people, even my patients, I work in an area where we have a local state park. It's called Sleeping Giant Mountain. For a lot of people out west, it's a little bump compared to what they have. But a lot of people go there because it's a great place to go hiking. They have all kinds of hiking trails. And I always say to them, are you using anything to prevent the ticks? And they say no. Well, don't you know those are the ones that generally come in with tick bites? And I have to educate people, even when I ask them about exercise. What do you do for exercise? Do you spend a lot of time outdoors? And again, even if you're outside gardening, I say the same thing. My 80-year-old patient loves to garden. Are you using anything to repel the ticks? She says, oh, I'm only in the garden. Well, where do you think ticks live? Mm-hmm. So it's really important that we educate our patients on the fact that it's not just in Connecticut. Like you said, you can go anywhere in Louisiana. You can go to the beach and find them on the beach in Rhode Island.
Wow.
Cape Cod. You can go anywhere. So we have to find out where our patients have been, and that's where the review of systems and the really good history taking is going to come in play.
Absolutely, which is what we should be doing all the time anyway. Now, I used to be told wear long sleeves and long pants and you should be fine. But now there is tick repellent that we need to all be using regardless of the clothes that we're wearing.
It adds an added layer of protection. So tucking your pants in, some people will say put elastic bands around your ankles and around your sleeves so that it inhibits the ticks from crawling in there. But what's going to stop them from crawling, dropping down your neck? All it takes is a blade, and the ticks quest. And what they do is they have 6 sets of legs and they have 2 pinchers. So what they do is they stand on their hind legs, waiting for an unsuspecting person to just walk by. And that's all it takes. And it can literally crawl up. You don't even know it's crawling up you. And it goes to a warm, dark, moist environment. So we usually see it scalp, under the arms, or in the groin. And then that's where it starts its feeding. But the thing is that the pinchers have a cement-like quality. So you don't ever feel that you're getting bitten. And they have this anesthetic property that prevents you from feeling that, but then the pinchers have the cement that keeps their head in there until they're ready to stop feeding, which is why it's so hard to remove them.
And so what is your recommendation on removing ticks?
So we tell people the old thing used to be, light a match, blow it out, and put the hot match on there. Well, the only thing that did was fry the end of the tick. The ticks breathe out their butt. So they have their pincers and their head is embedded. So they have to breathe out their butt while they're in their feeding meal. And people would also use a little bit of petroleum jelly, or they would use lipstick or even nail polish. The best way to do it is with a tweezer, where you actually press the skin down as much as you can around it and you pull straight up. If you pull on an angle, it's going to detach from the head. You have to actually go straight up. And if you've ever seen a tick on somebody or on a dog, when they feed and they're engorged, they usually are sitting straight up. You're not going to fall over. So it's just really trying to get the skin down enough where you have to pull it out. Many times you can't get it out. The head just detaches. And I usually, if they're in the office, I'll put a little bit of topical anesthetic spray on them and take it out with a scalpel. Some people will use a credit card if they're out in the woods and they'll try to push it away. But I tell them don't pick at it, because then you get a secondary bacterial infection.
Absolutely.
And if you're able to get it, they can take the tick to a local agricultural center for free. So in Connecticut, we have local agricultural centers. And because the Department of Public Health runs them, I always say it's really important, because not only are we going to find out what does this have in terms of Lyme or the other tick infections, but it's going to add to the body of knowledge that we need for the Department of Public Health. There's a number of other labs that will actually run the tick panel for you, like on an actual tick, but you have to pay out of pocket for it.
Oh, gosh.
Yes, and insurance doesn't always cover it. So they can check up to 9 different types, but it can be quite expensive, several $100s. And many of the patients don't have insurance, or they're underinsured. They're not going to pay for that.
Exactly. So if you had to leave us with 3 things today regarding tick-borne illnesses, what would those be?
So using some type of tick repellent, so Deep Woods Off, and I don't have any financial affiliation with them at all. They actually have DEET in them. And I know a lot of people don't like to use chemicals on their skin, but it is a known repellent for it. Essential oils have not been well studied, but they are known to be a repellent. So that's good to use on the skin, but you can't use the oils directly on your skin. You have to keep them in a vehicle. Or you can get something that's called permethrin. And permethrin is a 0.5% concentration. It goes on your clothing and it stays through 6 washings. So it's great for people who hike. I tell them spray it on the back of your backpack, your hats, your socks, whatever you're wearing, and it can last through 5 to 6 washings.
Okay.
And then just being mindful of the fact that you do a really good skin check on yourself when you come in, or have somebody in the house do that skin check, looking through your hair, looking in the different crevices of the body, because I've picked ticks out of a lot of different places on the body, and it's hard for the patients.
I'm sure
to
it
get
is.
them out.
Yeah. And then I would assume that if you are a healthcare provider, that if you have a patient that comes in with an insect bite, one thing you should always consider is it could possibly be a tick bite, and don't just dismiss it with a little mupirocin or hydrocortisone, but consider where they've been and what it could possibly be.
Exactly. Especially, again, this is the time of year that people are out. We saw an uptick, no pun intended, during the pandemic, because so many people were outdoors.
Yeah.
So we've seen more people that are coming in with, like you said, they just think it's an insect bite, when it really could just be, not every tick is going to cause the bullseye, but they can cause a little bit of redness. And you can tell the difference between a tick bite and a bee sting. So we really have to be mindful of, like you said, not just giving them mupirocin or cortisone cream, but let's run the tick panel in a couple of weeks just to make sure.
Just to be safe. All right, great. Well, Vanessa, thank you so much for joining me today again on NP Pulse. As always, it's a pleasure talking to you.
Thank you for having me. It's great to be back.
Thank you for joining us today on NP Pulse. I hope you enjoyed our guest today and learned as much as I did. Please subscribe to this podcast, share it with your colleagues, and check back regularly for new episodes. And as always, be kind, be safe, be effective, and be the voice of the nurse practitioner.